Thank you. And thanks for having me. These events I just find are a really impressive group of people, and I'm just happy to be a part of it again after coming to the last one. So I wanted to talk a little bit about, this is a great introduction, talking about human factors in general. And so I wanted to kind of bring some of these ideas and some design thinking to bear on what we do in the operating room in a way so that we can start to think a little bit differently about how we might approach medication safety. This is just an analogy. I'm going to talk a little bit about constraints, hopefully a relatable one if people have had TV remotes. This isn't my photo, I borrowed it, but my father-in-law did something similar, trying to understand how to cut out all of the unnecessary pieces so that you're left with what's useful. And it makes it much easier to do the right thing and cut out a lot of the noise so you don't do the wrong thing. So a current state of medications in the OR, anesthesia medication handling is very complex. We have several single point failures. We rely on vigilance and accuracy, which are two things we've already discussed the human brain is not most equipped for. And a lot of our countermeasures aren't really sustainable. And we've talked a lot about labels. Here's an example of poorly made labels. They require a lot of focus. They require standardization that we don't have. They don't physically prevent anything. And the big issue with labels is that they're trying to serve too many users. I don't care about 90% of the information on that label. If I had a pair of glasses that eliminated most of what was on a label, I could probably do my job a lot better. Because all I really want to know is what's the drug and the concentration per ml, and the rest of it is superfluous to me. Joyce and colleagues made a nice summary several years ago about all the medication safety recommendations from various organizations, including APSF, ISMP, and others we've heard about. And they identified 138 different interventions, which to me is really a red flag that what we're up against is really just too much complexity. Even when we put together the ISMP recommendations several years ago, it was a really useful process, and I'm proud of the outcome, but it was 30 pages long, which again, I think is a symptom that what we really need to do is think about simplifying and how to make things safer. So I like the analogy, I'm definitely pro color when it comes to the color or not debate. Originally when stop signs were first developed in the early 20th century, you did what you would probably do on day one. You made a big black square, and most people didn't really stop. They didn't really standardize. They were in kind of odd places. So over time, we developed ways that made it easier for people to identify. Now it's based on shape and color and location, in addition to what you actually read on the sign. So that's why it's standardized with stop lights are red, stop signs are red. They're things that they have done. So now at least when people run a stop sign, it's not usually because they didn't see it, but maybe for other reasons. We've talked as well about how our unique workflow is different from the rest of the hospital. A lot of people view that as a vulnerability, and it can be certainly, but I also think it's a unique opportunity. I think it's worth bearing in mind that the top workflow, which most of the rest of the hospital does, was not designed with safety in mind. I mean, certainly there have been interventions to try to make it safer, but it's really more of a manufacturing mindset of specialization and efficiency. And what we have down below is both a unique opportunity to try to really craft what we do that's different. And I don't think taking the wholesale lessons from the rest of the hospital is necessarily going to be the best solution. So several years ago, a colleague of mine, Liz Martin, did a failure mode and effects analysis looking at the medication process in the OR. Many of you have seen this slide before. I know you can't read it, and that's kind of the point. This was really prospectively looking at what we do every day in the operating room. We identified 5 major steps in terms of getting a medication from vial to patient, 19 sub-steps, and 68 possible failure modes. So that again speaks to this idea that what we do is much too complicated, and really what we need to do is come up with ways to simplify it in order to make it safer, not necessarily add things on top of this. So again, this hopefully is a familiar slide to any of you interested in human factors. There's a lot to unpack here I don't really have time to get into, but the main thing I want to talk about is there's various levels of interventions that we can talk about. And things like education and rules are pretty low on the hierarchy of effectiveness. And things like forcing functions, constraints, automation are going to be much more effective, much more reliable, much less reliant on user participation, and ways to sort of force people to do the right thing, obviously with the asterisks of, within reason and in useful ways that work with their workflow. So we've talked a lot about the history of anesthesia safety, and hopefully most of you are familiar with all that work that was done in the 80s and 90s, looking at the machine when they identified that airway and oxygenation was the big problem. And so there was a huge amount of work that went into the anesthesia machine, designing it in a way that made it really difficult to deliver a hypoxic mixture. This is like Anesthesia 101, first day of residency. They go through all the various things in terms of how the flow meters are set up and the pin index system and all the various physical constraints that make it really hard in a modern anesthesia machine to not deliver at least a life-sustaining amount of oxygen. And yet on the other side of our workspace, we have very few of those today. We don't really have a lot of constraints that prevent us from doing really bad things. We've seen several examples this morning, some of which have been repeated over and over, which is a little disheartening. But hopefully after today, we can walk away with some ways to make that better. So we don't have ways to detect errors most of the time. I mean, if you give the wrong dose, it's usually something discovered much later. You know, we don't have alarms about giving the wrong dose when you're bolusing medications. So starting to think about how can we make the medication side of our workspace start to look a little bit more like the machine side. So I think there's sort of two ways that are useful to think about this. One is sort of feedback versus constraints. Feedback is labels, you know, it's alarms, it's various things that can be helpful, but does require a certain amount of engagement and a certain amount of compliance. A much more robust are constraints, which eliminate steps, automate processes, and ideally physically prevent mistakes. That we may not always be able to get to that level of intervention, but again, conceptually, I think it's helpful to think about, are there ways that we can physically eliminate problems, things don't fit together, things like that. And so some examples, you know, color-coded syringes provide at least some useful feedback, barcode scanners, labels, and provider checks. But really on the other side, you have more robust constraints like smart pumps that won't let you give a lethal dose of a medication. You know, if you have standard pharmacy concentrations, then you're not going to have a bunch of other options that can create confusion. Pre-filled syringes, I'll talk about a little bit more in a second, but that eliminate even this whole question of vials and vial swaps, et cetera. So a couple examples of constraints that we'll see around the operating room. Top left is the medication layout tray that we use at Seattle Children's and a couple other places around the country. The nerve fit we've talked about this morning, how you can't physically connect the wrong medication or at least the wrong syringe to an neuraxial catheter. Again, constraints on infusion pumps can be programmed in certain ways and have certain limitations so that you can't do something that's going to cause a lot of problems. I think another way it's useful to think about this is adding to an already complex workflow versus subtracting things away to try to simplify. So one of the things I worry about, and we talk about this TSA analogy of you have airport security and then the next day you take your shoes off, and then the next day you take your liquids out, and the next day it's more and more, and it keeps getting more complicated. I worry a bit about some of the interventions that we've talked about. You know, barcoding at the point of administration, I think has value, but essentially you're asking someone to do something probably about 10,000 extra times a year for something that's not very common. And it's going to be a bit of an uphill battle to get people to do that regularly and consistently and make it part of their workflow. So I think it's more helpful to start thinking about, are there ways to subtract problems from the system? So one of my favorites is pre-filled syringes. Going back to our failure mode and effects analysis and going through all the various steps, you know, pre-filled syringes alone will eliminate 6 sub-steps and 19 failure modes, just like that, just from those syringes, because all that vial preparation, vial swaps, all this TXA, phenylephrine things we've been talking about this morning, a lot of that goes away. It's not 100% foolproof, but now suddenly all these vial issues disappear, and it's a really robust way. You know, again, with the asterisks, we've been through 304, 503Bs, and we have supply issues, and there's other challenges. But I think it's useful to think conceptually of, can we take pieces of this system out? You know, can you make pharmacy prepare infusions for you so that that's not something you're doing in the OR? Like, why are we even doing all this medication preparation in the OR? If you couldn't, you would be hard pressed to design a worse space to be doing med preparation than an operating room. The other thing I just want to mention, there's a lot of med safety adjacent concepts that worry me. And I just want to sort of keep in mind when we're thinking about medication safety that we don't confuse it with other things that I found in my institution, particularly from the administrative side, often get confused with med safety. So sometimes we borrow ideas wholesale from somewhere else. So the 2-provider check. I think it can be very useful. We do it at my institution for local anesthetic specifically, but in an operating room, it may not always be practical. You may not always have two people around. You may need to find a solution that's going to work better. Again, barcoding, I think, can be valuable, has an important role, but it's not something I would want to take wholesale, pretending like we are the floor at that same pace and cadence, because what we do is quite different. I think the automated dispensing carts can be useful for a lot of reasons. I don't think medication safety is typically one of them. It's very helpful for wasting medications. It's helpful for pharmacy to keep track of things. But I feel like oftentimes administrators roll these new technologies in and say, look, it's going to make your practice safer, when I would argue it isn't necessarily. There's also these challenges of when we can't really get to the root problem. We've had several examples today of lookalike vials. I think this group is maybe uniquely positioned to try to make some headway, but for the most part, from a healthcare institution perspective, we have no control over supply chain shortages, what vials look like. And so we do a lot of things to try to prevent vial swaps, but as long as they come in this random rainbow of colors, it's going to be very hard and something, again, an uphill battle we're going to be constantly fighting. And then I think sometimes we do get overshadowed by other parts of the hospital or other priorities. You know, this whole back and forth about color coding is often less a concern about the operating room and more about the rest of the institution. And so because we are a relatively small piece of the medication puzzle, I think sometimes we get overshadowed by priorities in the rest of the house and not tailoring solutions to our unique workflow. And so the question I like to ask is, you know, why doesn't anyone talk about barcoding sevoflurane? It's because we have all these robust mechanisms that are in place, from the, you know, the key to fill it to measuring it as we give it and how much of all these other things. And if we could do more things like that on the IV medication side, then we might find we don't need some of these other additive interventions. So I just like it as a thought exercise to sort of think about like subtractive questions in terms of how can we eliminate steps. Again, you know, eliminate vials, pre-filled syringes. Is there a way to eliminate syringes? You know, why do we rely so much on labels? Mental calculations is a huge one in pediatric anesthesia where I practice. I don't necessarily have a solution for all this. You know, we have various job aids and things, but again, just sort of thinking about how to unburden the user and how to simplify their workflow. You know, the interoperability issues about syringes and NERFIT and NFIT and all that. And then similarly, how do we automate various processes about drug selection, you know, concentration, so that we have, you know, the fewest that we are trying to deal with, automating recordings, so you're not spending as much time interfacing with the EHR, you know, various other interactions, allergies, et cetera. So we talk about, you know, constraints, but useful constraints. Constraining to afford is a human factors term about, you know, making sure you can do the thing that you really want to do. So we're not trying to prevent you from doing your job. I mean, it's the job I'm trying to do as well, certainly, but trying to make it really hard to do the wrong things. And so today, you know, we talk about error reduction, simplifying, standardizing constraints. And I think tomorrow there's probably an opportunity to get closer to a much more streamlined workflow. Those of you who have seen this talk before, you know, I talk about the espresso machine or soda machine or something, you know, someday maybe we'll just push a button and all the other medication stuff just happens automatically. That's the dream. It's not practical today, but I think it's a useful thought exercise about how can we really simplify what we do rather than adding double checks and other things on top of it to make it more complicated. Because, you know, our job is very complex. The thinking piece is never going to go away. We're not suggesting that. We just want the execution piece to be much more simple and automated so that we're much less likely to make mistakes. Thank you.